Good evening, everybody. My name's Dr. Andy Smith. I'm the president and CEO at Sunnybrook Health Sciences Center. It is my absolute pleasure to offer the introductions for tonight's speaker series on dementia. These lectures continue to offer an important connection to you, our community, and also a chance for many of our experts to provide trusted health information to those who need it. Please consider joining our mailing list to learn about upcoming topics. You can also access upcoming lecture information on the speaker series website where you have accessed this evening's talk. So tonight's discussion is one that affects many people and their families: dementia. Here at Sunnybrook, this is an area that we focus on a great deal already, and it will be a major focus in our new Gary Hurwitz Brain Sciences Center. And if you've been around the campus here at Bayview recently, you'll know that that building has really come out of the ground now and is really going up. So we're very excited about this. So it's currently under construction, and when done, it really will be the first of its kind in Canada. Once built, this state-of-the-art facility will be a unique and collaborative space, leading the way for revolutionary solutions to the most devastating brain disorders. It will be a global hub of innovation and a space to accelerate discovery of the next generation of treatment, prevention, and possible cures to the world's most debilitating brain conditions. So tonight, we're very fortunate to have Dr. Sandra Black moderate tonight's discussion as Changing the World, how we understand Alzheimer's disease and other dementias. This has long been her focus. And Dr. Black, I hope you don't mind mentioning that I've been around Sunnybrook since the 80s, and you were my teacher back then, and I never did well becoming a neurologist. But
he was a very good student, very good student.
So Dr. Black is a senior scientist, a renowned neurologist, and she leads the Dr. Sandra Black Center for Brain Resilience and Recovery. Dr. Black is a true leader in her field, and she's is joined by an incredible panel of experts for tonight's speaker series. So you're in for a very informative evening. And without further ado, I'll pass the microphone over to you, Dr. Black. Thank you very much, everybody, for being a part of this discussion this evening.
So I'm delighted to be here. Thank you so much, Andy. And good evening to all of you who are joining us remotely this evening. We were just saying that it can't be in person, but we maybe can invite people more easily to join us for these occasions. Tonight, our lecture is called Evening Discussion on Dementia. And as mentioned by Andy, we are very lucky to have a great lineup of speakers for you. Dr. Sarah Mitchell will get us started with her presentation focusing on dementia care during a pandemic, virtual care, and beyond. Dr. Jennifer Rabin will then discuss how your lifestyle can protect you from dementia. And then Dr. Krista Langtolt will tell us about intervention trials to prevent or delay dementia. We'll set aside some time at the end of the evening for you to ask questions of the panelists. Thank you very much for those of you who already submitted questions online. You can keep sending in questions. We won't have time to answer them all, but we will certainly try to answer what we can. And if we do not answer your question, you may be able to get in touch with the person that you want to answer the question. So to begin, I'd like first of all to introduce Dr. Sarah Mitchell, who's a staff neurologist with the Hurwitz Brain Sciences program. We're very glad she's here to provide some guidance on dementia care during a pandemic and ways to reach and care for patients, including virtually. Without further ado, I'll pass the microphone, so to speak, over to Sarah.
Thank you so much, Dr. Black.
Okay, I guess we go on to talk mode and you share the screen.
Yes. Can everyone see that okay? Excellent. Thank you so much, Dr. Black, Dr. Smith. It's an honor to be here. And thank you to Dr. Rabin and Dr. Langtolt for the opportunity to speak alongside you. This is a really important topic, and I'm very happy to be able to reach the Sunnybrook community and beyond to discuss this important topic of dementia care. So today I'm going to be talking to you about dementia care during a pandemic, which is obviously very relevant for many of us who've been living through the past few years. And we're going to be looking specifically at virtual care and how we can harness the power of virtual care to treat dementia patients. I have no disclosures that are relevant for tonight's talk. And in terms of my learning objectives, I wanted to discuss with you how virtual care shifted towards treating dementia in a population during a pandemic. I also want to talk to you about what the literature says, so what evidence there is on delivering care to patients with dementia remotely. And finally, we'll talk about some of the barriers and maybe some solutions to barriers in virtual care delivery. Before we talk about the pandemic, let's talk about what we were facing, what we were up against before the pandemic. So before this pandemic hit, dementia was referred to as a golden tsunami, a very formidable healthcare crisis that we were all facing with a rapidly aging population. And this was because the prevalence of dementia was rising worldwide. Many statistics quote that 50 million people, and likely many, many more, because it's underreported, were suffering from dementia, and that number was expected to triple by 2050. This is also a problem locally within Canada, where at least 500,000 people are living with dementia. And like many of you, 1 in 5 Canadians identify as caring for a loved one who suffers from dementia. Then came the COVID-19 pandemic. And what happened was that this pandemic really disproportionately impacted people living with dementia. And that was a fewfold. The reasons for that were a fewfold. The first is the fact that dementia, the presence of a diagnosis of dementia, increases your risk of contracting COVID-19 for a number of reasons, including perhaps being unable to comply with public health measures due to cognitive impairment, as well as potentially living in nursing homes or other congregate settings where infection risk and transmissibility is high. Also, having a diagnosis of dementia not only increases your risk of getting COVID-19, but also of having a poorer outcome. Some of the statistics quoted, especially in the earlier waves, were that it adds about a 40% risk of death if you're hospitalized with COVID-19 and you have a diagnosis of dementia. And locally within Canada, the mortality statistics bore out the same. So about up to 40% of women and 33% of men who were listed as having COVID-19 deaths had dementia listed as a comorbidity. And in part, this is also because dementia is much more common as we age. And we know that age is a really, really potent risk factor as well for COVID-19 poor outcomes. What is more is that the pandemic introduced public health restrictions that really disproportionately impacted patients who are reliant on community services and social integration and social care services for their ability to thrive. What we saw was an increase in patient distress as well as in caregiver burnout. And this resulted from things such as day program closures, which are such a critical element of many patients with dementia's daily routines, PSW support that was either reduced or entirely ceased or did not continue, changes to day-to-day routine, which can introduce much derailment in a patient with dementia and is so important for keeping confusion at bay as well as symptoms that result from increased confusion. And then finally, just the social isolation in general. We always tell our patients that social interaction and social stimulation is one of the core tenets of brain health, of keeping your brain healthy. When you start to really take that away from patients, they really struggled. So there is data to suggest that there is increase in neuropsychiatric symptoms in patients with dementia, which include things like depression, anxiety, difficulties with sleep, wandering and agitation behaviors. And while the patients were really vulnerable and needing more and more care, we were really worried about transmissibility to this population for the reasons I outlined before. So enter virtual care. We had to innovate through the delivery of virtual care to this population. And what I have here is something called the Prochaska model of change, which is just basically anytime you're thinking of taking on a new behavior, you go through a different stage of thinking about that behavior. So you pre-contemplate, you contemplate, you prepare, and then you finally act. Many physicians were sort of in the pre-contemplative or contemplative phase of using virtual care. Not many were early, robust adopters. And so the pandemic really thrust people into the action mode because we had to deliver and we had to deliver quickly. And we didn't have much time to think. And a lot of our regulatory bodies were suggesting that virtual care needed to be delivered. Just so we're all on the same page, what is virtual care? Well, a definition is that it's basically the use of technology to facilitate an interaction between a patient, a healthcare provider, and the healthcare system more broadly. And this allows us to provide care to novel settings, direct to patients' homes, direct to long-term care facilities, or other third-party locations, other than the typical patient doctor visit in a typical setting of a hospital or other healthcare setting. And virtual care modalities span more than you might realize. So we often use the term digital health, thinking about things like not just the telephone, but also video teleconferencing platforms, a few of which are listed here, like Ontario Telemedicine Network or OTN, Zoom teleconferencing, but also things like emails, e-consults, which is a specialty consultation program that we have in Ontario, electronic medical records, and then also things like remote digital monitoring and tools. Now, when we apply virtual care to a dementia assessment, we have to think about all the different components that are integral to assessing a patient with dementia and providing a diagnosis. So this includes an expert assessment, which can be done by a general practitioner, can be done by a specialist of many stripes, geriatricians, cognitive neurologists, geriatric psychiatrists, et cetera. It involves taking an in-depth and detailed history, both from a patient as well as from an informant or third-party caregiver, for instance. And then it involves doing some cognitive testing to see how the brain is functioning, doing neurological examination maneuvers to look and see how the nervous system is operating, and then determining level of function and reviewing relevant investigations. You can see from this list here that some of these are a bit more intuitive in terms of how you would do it from behind a screen, but two in particular really stand out as being not as intuitive, and that includes the cognitive evaluation and neurologic exam. So this was a study that we did, published in the Canadian Medical Association Journal, looking at what evidence is there for virtual cognitive examination. And what we found was actually that there's good diagnostic agreement for cognitive tests that are conducted virtually and then in person. But we still need to do quite a bit in terms of validating this data. And we also need to do quite a bit in terms of looking at how well we do in terms of implementing these direct to a patient's home. So listed in this table here, which is taken from the paper, there's a few different common bedside cognitive tests that you might get or might see someone get when you visit the doctor's office. And that includes tests like the mini mental state exam, for instance, which is a very common test. And for all of these, we looked at a number called the intra-class correlation coefficient. And we found that there was actually pretty good agreement in terms of the scores that patients got virtually or in person. We then looked towards the virtual neurologic exam, and there really wasn't much within the literature about how to do this through the screen. It's quite a sophisticated exam. It's very tactile, meaning that it involves reflexes and testing someone's power. And so it's not very intuitive how to do it. So what we did was we created some training videos looking at how to potentially implement aspects of the neurological exam virtually. And now we're working on a study to try and validate aspects of the virtual neurologic examination that are done through a screen and then in person to see how well we're doing. But this has not been well studied in dementia. A full neurological examination for some basic mild cognitive impairment or Alzheimer's disease, perhaps some of it can be done with more of a screening neurologic exam, but certainly we need to look for rare dementias and for those with motor involvement. We need to be looking at patients a bit more in depth than we might be available virtually. So we need to be looking a bit more at this, how well we're doing from this respect. In terms of how well we're doing in terms of virtually diagnosing patients with dementia, there's actually good diagnostic agreement between giving a diagnosis, so saying, yes, you have a diagnosis of, for instance, Alzheimer's disease, if you see and assess the person through a screen versus if you see them in person. But a lot of this data was from before the pandemic, when patients would go to a third-party assessment center. So they may have access to supplemental information, which means they may have tests and other things available, the doctor who's doing the assessment, compared to what we might have when we're doing a direct-to-home assessment now. So more work needs to be done in this area as well. But one thing that does come out is that it's quite feasible to diagnose dementia virtually, and especially in rural settings where people may not have access to specialists. It may actually increase our reach in terms of the population that we're trying to serve. What about follow-up and management? We know that dementia is a progressive illness, meaning that the symptoms continue to worsen over time and patients face additional obstacles. They may have worsening mobility or ability to walk around. They may become more confused and disoriented, agitated, and they may require more caregiver reliance. And so we actually saw that within the literature, virtual care has evidence to start and manage medications, to connect patients and their families with services, to discuss safety and planning, to determine investigations that are needed, and to reassess cognitive decline over time. And in fact, it can adequately identify when patients are transitioning from different stages of dementia, from a milder stage to a more severe stage, like the transition from what we call mild cognitive impairment to the dementia stage. There also are potential benefits from virtual care that one might not expect. Improvements in quality of life over 12 months have been shown, ability to maintain pharmacological management for longer over time. And also a really important and potent one is this ability to manage behavioral symptoms in a way that we never could previously. And there's been some excellent leading work innovating in this space from the U of T community, including at Sunnybrook locally, Long-Term Care Plus, which was led by Dr. Brian Wong. Dr. Morris Friedman is another one who's really leading the way with a program called Virtual Behavioral Medicine. And it's showing that we can use virtual care to actually address behavioral symptoms and agitation and monitor it well over time in the comfort of the patient's own home or care facility. And what do patients think about virtual care? Well, from what we can see thus far, there's high rates of satisfaction from both the patients, the caregivers, as well as from many of the physicians. And things that people enjoy or cited as advantages are time saved, so lack of having to commute, improved access to specialists, and saving money on time, mileage, and as we know, places like Sunnybrook and other hospitals do have payment for parking, so that was always cited as well. So we're talking about all the advantages of virtual care. Of course, there are some great hurdles and barriers that we have to deal with in the coming times, including really how do we get around the integral need for caregiver involvement. That is the case as well in person, but certainly at home, that can be a really important element to the assessment, as well as things like access to technology. What if patients don't have access to a computer, to a telephone, to internet services? What if they don't have the technological literacy to set up the appointment to participate? And so one of the ways that we looked at this is in terms of solutions is trying to empower any third party that is available to be able to help facilitate the interaction. That can be family, friends, but also local health centers. And there's certainly a role for the healthcare system to support virtual care, including providing technological access to patients who may not have it otherwise, as well as technical literacy programs, if possible. And also making sure that there's good preparatory material. So this was as part of I was the co-lead for the Department of Medicine Virtual Care Task Force. We created a lot of different types of materials to help facilitate and prepare patients for virtual care, as well as to prepare other physicians and administrative assistants to help with the preparation. Another commonly cited barrier is, what does it do to the physician-patient relationship? And we know that physicians are trained very well in bedside manner, meaning how we talk to patients and convey information in person, but we may need to do additional training on webside manner, which is really, it's not intuitive where to look even. Something as simple as eye contact between a patient and physician can be lost through the virtual interface. And a lot of work is also being done at the University of Toronto through medical education to try and improve medical training for both physicians as well as help with the interactions. We also need to look at how well sensitive topics are delivered, diagnoses, even something like cognitive impairment can be a very devastating diagnosis, and how well are we doing this virtually and how are patients receiving it? And finally, we need to look at diagnostic challenges. Certainly, dementia patients may have more likely to have sensory impairment, so we need to make sure that hearing aids and glasses are being utilized at every interaction. We need to harness the use of screen sharing technologies, as well as things like printing cognitive assessments and providing adaptive technology as necessary. And finally, and ultimately, there are limits to virtual care, recognizing those limits, documenting uncertainties, and verifying with in-person assessments, and continuing to study how virtual care is able to provide care to this patient population. So that brings me to my last slide, just to summarize and talk a little bit about future directions. There is evidence that virtual cognitive assessment tools are reliable, that virtual care is feasible and well accepted in the diagnosis and management of dementia. But I think ultimately virtual visits will be used to supplement rather than replace in-person visits over time. And we really need more data on direct-to-home virtual visits, especially in the cases of rare dementia diagnosis. Ultimately, the success and the future of virtual care lies in collaboration between clinicians, patients, caregivers, and the broader healthcare system. And we'll need to continue working together towards that future. So these are just back to my learning objectives. I thank you very much for your attention and interest, and we'll get to questions.
We're going to answer questions later at the end, so stay tuned. And thank you very much for a great overview of this whole opportunity that has risen partly because of COVID, the silver lining of COVID, I guess. I'd like to now introduce our next presenter, Dr. Jennifer Rabin. Dr. Rabin is a scientist within the Sunnybrook Research Institute. Her specialty is neuropsychology, and she'll be discussing how lifestyle can protect you from dementia. Over to you, Jennifer.
Thank you, Dr. Black, for the very nice introduction. I just want to make sure that everyone can hear me okay and see my screen. Okay, great. So yeah, it's my pleasure today to talk to you about how your lifestyle can protect you from dementia. So Alzheimer's disease remains one of the most feared consequences of aging. And I think that part of the fear around this devastating disease stems from the fact that it's often thought there's nothing we can do about it. Despite knowing about the disease for more than 100 years, we still don't have any effective disease-modifying treatments, and there is still no cure. But what if I told you that I have a way for you to protect your brain health into old age so that you can reduce your risk of dementia? And what if I sweetened the deal and told you that there's no side effects associated with this approach? Would you be interested? So today I'm going to tell you about this approach. And specifically, I'm going to tell you how your lifestyle choices can protect you from dementia. Before delving into this issue, I first wanted to go over some terminology. So often when I speak to people in the community about Alzheimer's disease and dementia, there's some confusion between the two terms. So I just wanted to take a moment to explain the difference. So dementia is an overall term or an umbrella term that's used to describe a decline in thinking abilities that's severe enough to interfere with day-to-day activities. So in the case of dementia, the decline is quite substantial and much greater than what you would see in normal aging. Now, there's many causes of dementia, and Alzheimer's disease is just one of them. But it's the most common cause of dementia, and that's likely why it's so often confused with the term dementia. But as I pointed out, there's many causes of dementia, and I've listed a few of them here. So Alzheimer's disease is defined by the abnormal buildup of amyloid plaques and tau neurofibrillary tangles in the brain. And so you can see that here in the brain of a patient who died with Alzheimer's disease. So these orange clumpy things are the amyloid plaques that developed within the neurons or the brain cells. And these black stringy things are the tau tangles that develop between the neurons or brain cells. And as amyloid and tau begin to accumulate in the brain, we start to see brain cells die, the brain shrinks, and that's when we start to see memory and thinking problems. And that ultimately leads to a diagnosis of dementia. Okay, so now back to risk factors for dementia. So what is a risk factor? A risk factor is something that increases the chances of developing a condition like dementia. And there's many risk factors for dementia, and I've only listed just a few of them here. Now, there's some risk factors for dementia that we can't change. So this includes our age and genetics. We've known for a long time that older age and certain genetic factors can place people at greater risk for developing dementia. But I've really been most interested in the factors that we can change or that we can modify. And recent research suggests that up to 40% of dementia cases are linked to modifiable risk factors that we have the potential to change. And so what this means is that 40% of dementia cases could potentially be prevented. So just think about that. So today I'm going to focus on a few of those modifiable risk factors. And I'm going to start with vascular risk factors. So vascular risk factors are conditions that can affect blood flow in the brain. So this includes things like high blood pressure, high cholesterol, obesity, diabetes, and smoking. Now, any one of these risk factors here can increase the risk of dementia. But it's often the case that people present with multiple vascular risk factors, and this can increase the risk for dementia in an additive manner or even an interactive manner. So how do these vascular risk factors lead to dementia? Well, the brain is outfitted with a rich supply of blood vessels, which are necessary for the delivery of oxygen and nutrients. And the further and deeper into the brain these vessels penetrate, the smaller they become. And these smaller blood vessels are incredibly vulnerable to vascular risk factors. And with extended exposure to these risk factors, these vessels can harden and thicken. And this in turn reduces blood flow to the brain, causes brain cells to die. This in turn impacts memory and thinking abilities, and ultimately leads to dementia. So the good news is that we know how to treat vascular risk factors. We know how to treat high blood pressure, high cholesterol, obesity, diabetes, and we have effective strategies to help people stop smoking. So I've listed a few things here that you can do to help keep your vascular risk in check. So one thing is that it's really important to keep up with routine doctor visits, so these conditions can be monitored on a regular basis. If you've been prescribed medications for high blood pressure, high cholesterol, or diabetes, these medications should be taken as directed. Recent research has shown that when people have high blood pressure and then go on to take medication for their blood pressure and bring it into normal range, dementia risk is reduced. And finally, it's very important to eat a healthy diet and to exercise regularly. So these lifestyle factors have been shown to reduce the likelihood of developing these conditions. So a good rule of thumb is that what's good for the heart is good for the brain. Or to think about it the other way, what's bad for the heart is also bad for the brain. The next risk factor I want to talk about today is something called low cognitive reserve. And this might be a term that you're unfamiliar with. So cognitive reserve refers to the brain's ability to cope and keep working even when there's damage to the brain from injury or diseases like Alzheimer's disease. And researchers think that engaging in mentally stimulating activities throughout one's life can help to build up a high cognitive reserve. So let me introduce you to Sister Mary. So Sister Mary was enrolled in a study that examined thinking abilities or cognition in the late 1980s. And nuns were chosen as subjects in this study because of their very similar and relatively clean lifestyles, making it easier for researchers to isolate the factors that influence cognition. Now, Sister Mary was exceptionally passionate about education, and she continued to teach well after her retirement at the age of 84. She was an avid reader, very social, and she remained heavily involved in community activities until she died. Now, when Sister Mary passed at the age of 101, her brain autopsy showed advanced Alzheimer's disease. So her brain was filled with those plaques and tangles I showed you earlier. Now, at the time, this was exceptionally surprising to the researchers because until the very end of Sister Mary's life, her scores on cognitive tests were better than those of adults 30 years younger than her. And she also barely declined from her scores in previous years. So this was a seminal study that showed engaging in mentally stimulating activities over the course of one's life can help to build up a high cognitive reserve, which can help to protect against the symptoms of Alzheimer's disease and other dementias. And this phenomenon of cognitive reserve has now been replicated over and over again in the literature. It's a really robust finding. And because of these findings, researchers now recommend keeping the mind active throughout one's entire life, and especially after retirement. So it's not entirely clear what activities might be most beneficial for the brain. So researchers just recommend engaging in any activity that you find challenging. So if any activity that you enjoy and find challenging. So this will ensure that you keep your brain active on a regular basis. So this can be anything from playing chess to socializing, reading novels, doing jigsaw puzzles, or attending a lecture like you are today. And when I often talk to people from the community about keeping their minds active, I get the question about brain games such as Lumosity. Now, there's nothing really special about these brain games that help to stave off dementia. So if you like it playing these games, then I think that's great. You should continue with them. But if you force yourself to play these games in the hope that this will stave off dementia, you're likely better off finding other activities that you actually enjoy and find challenging. So the next risk factor I'm going to talk about is physical activity or physical inactivity. So several studies have shown that regular physical activity can significantly reduce the risk of developing dementia. So in a recent study that we did, we examined physical activity in older adults who already had Alzheimer's changes in their brain, and we followed them for up to 8 years. Now, at the beginning of this study, we gave participants a pedometer like this to wear around their waist so that we could track how many steps they took each day. And then every year they were in the study, we measured their thinking and memory abilities using standardized cognitive tests. And what we found is that individuals who had high physical activity or who took more steps per day performed better over time on memory tests. So let me walk you through this plot here. So on the x-axis, I have memory performance, where the lower scores represent worse performance. And then on the x-axis here, I have time in years, so up to 8 years here. In blue, you can see the participants who had high physical activity or who took a lot of steps per day. And then this red line represents participants who are relatively sedentary. And even though both of these groups of participants had Alzheimer's changes in their brain, you can see that participants who took many steps per day, so at least 8,300 steps per day, had very little decline over time. But participants who were predominantly sedentary and took few steps per day had quite rapid decline over time. So these findings suggest that engaging in physical activity can help to protect against dementia. And in this study, we also looked at vascular risk factors. So recall, those are things like high blood pressure, high cholesterol, diabetes, and obesity. And what we found in this study is that participants who had good physical activity, who took many steps per day, and had good physical health, who had good vascular health, benefited from both of those things and had the lowest memory decline over time. So there were independent effects of physical activity and vascular health on memory performance. So in terms of physical activity, it doesn't really matter what activity you do as long as you get your heart rate up. But we do know that people are more likely to exercise if they find activities that they enjoy. We also suggest that people opt for activities that they can do with other people, like walking or dancing. So when people exercise with others, you're now not only exercising your body, but you're also exercising your brain because of the social aspect. It's also a good way to motivate each other to engage in physical activity more often. Current guidelines recommend engaging in at least 150 minutes per week of physical activity, but we really know that engaging in any amount of physical activity is better than nothing. So the last risk factor I want to speak about today is poor sleep. So I think all of us can relate and know that a bad night's sleep can impair our ability to think the following day. And research has shown that getting too few hours of sleep can also increase the risk of developing Alzheimer's disease and dementia. And one important finding that's emerged from the literature is that sleep might be particularly important for clearing out harmful toxins from the brain. So we think that when the brain is asleep, it's optimized for washing away harmful proteins that build up during waking hours. So you can kind of think of it like a dishwasher that turns on at night. And one of the waste products that the sleeping brain clears out is amyloid. So one of those proteins that I showed you earlier that's associated with Alzheimer's disease. Now, just to really hit this point home, I wanted to show you some data. So in this study here, the authors examined the association between excessive daytime sleepiness due to poor sleep and amyloid accumulation over time. And the authors found that participants who reported more daytime sleepiness showed greater amyloid accumulation over a 2-year period. So let me just walk you through this. On the y-axis here, I have amyloid accumulation, and on the x-axis, I have different brain regions. This dark blue box here represents the participants who reported no daytime sleepiness, and this light box represents participants who reported a lot of daytime sleepiness. And what you can see here is that across the different brain regions, participants who reported more daytime sleepiness had faster amyloid accumulation over a 2-year period. And so this finding provides support for the idea that sleep might help clear amyloid from the brain and therefore reduce the risk of developing dementia. So just to summarize what I spoke about today, there are many things that we can do to preserve our brain and cognitive health to protect ourselves from developing dementia. I just mentioned a few of these things, including managing our vascular health, engaging in physical activity, keeping our minds active, and getting a good night's sleep. And it's really never too early or too late to make these kinds of changes. So I'll leave you with one question today, and that's what lifestyle changes will you make to reduce your risk of dementia? So thank you very much for listening, and I look forward to your questions during the question period.
Thanks very much for a great overview of what you can do. So maybe we'll take a brief pause and let everybody try to answer that question for themselves before we go on to our third and final speaker. And there will be some time for the questions that have been accumulating that people have sent in, and we will try to answer as many as we can, but you can still add to the questions through the Q&A box, I think. Okay, so everybody has silently answered the determination of what they're going to do to help their brain age more healthily. And now we'll move on to our final speaker, who is Dr. Krista Langto, who is a clinical pharmacologist and senior scientist within the Hurwitz Brain Sciences program. Her presentation, she's been doing clinical trials and epidemiological studies for a number of years and has a lot of experience with this. And she's going to talk to us about intervention trials to try to prevent or maybe delay the onset of dementia. She could talk about treating dementia, treating apathy, treating all sorts of things, but she's going to talk about preventing and delaying dementia. Krista, microphone is yours.
Thank you very much. Am I unmuted? Yes, I'm unmuted. Okay. Had to stop screen share to make that. Okay, I will screen share and set up. All right. I'm glad I gave us ample time to think about how we're going to change our lifestyles while I set up my slides. Thank you for the introduction, Dr. Black. So tonight's about dementia. As we've already heard, dementia is an umbrella term used to describe a whole range of symptoms associated with cognitive impairment. And those symptoms can include memory loss, which is commonly noticed by others, difficulty communicating and finding words, difficulty with visual and spatial abilities, such as getting lost while driving, difficulty reasoning or problem solving, difficulty handling complex tasks, and difficulty with planning and organization. Alzheimer's, shown in purple, and vascular cognitive impairment, here shown in green, commonly co-occur. And as we've heard, together they account for the majority of cases of dementia. We all have one of the major risk factors for dementia, age. The Canadian Study of Health and Aging shown here included more than 10,000 Canadians aged 65 and older. As you can see in the graph, the prevalence of Alzheimer's disease increases dramatically with age. While between the ages of 65 and 74, 1% of men and women would be expected to have Alzheimer's and related dementias. By the time you're 85 plus, 1 in 4 Canadians are expected to have Alzheimer's disease and related dementias. There's a second group of risk factors that many Canadians had. We heard already about vascular cognitive impairment. Those are cognitive disorders that are associated with cerebrovascular disease, or diseases that affect blood flow and the blood vessels in the brain, like stroke, and heart conditions like coronary artery disease. 90% of people in Canada have at least one risk factor for heart conditions, stroke, or vascular cognitive impairment. And those include the risk factors we just heard about: diabetes or smoking or hypertension or hypercholesterolemia or obesity. Because of this, the incidence of Alzheimer's disease and related dementias in Canada is expected to rise with the aging of the population. For example, in 2008, we had about 100,000 new cases per year, 1 case every 5 minutes. But in the next 20 years, we expect that to more than double, with over 250,000 new cases per year, or 1 every 2 minutes. We've heard the good news that we can help that by lifestyle interventions. We've heard the importance of diet. The Alzheimer's Society of Canada recommends diets low in fat and high in antioxidants. One example of this is the Mediterranean diet. A recent study by Singh et al. That was a review showed that with the Mediterranean diet, there's a 27% lower risk of developing mild cognitive impairment, that's the pre-dementia stage, and a 36% lower risk of developing Alzheimer's disease. So one feature of the Mediterranean diet is that this diet is high in a proportion of foods that contain antioxidants. So I'd just like to show you why you need antioxidants. Your body produces and eliminates reactive oxygen species, or ROS, every day. And antioxidants are the natural chemicals that your body makes that eliminate ROS. When we talk about oxidative stress, it's the imbalance between the production of ROS and your body's ability to eliminate them. Excess levels of ROS can damage proteins and contribute to brain cell loss. So I showed you a diagram of low reactive oxygen species and the potential role that antioxidants can play. Which population might particularly benefit from additional antioxidants? As you've heard, cognitive disorders are associated with heart diseases like coronary artery disease. Heart disease puts a brain at risk. For example, in a recent study, we found that 22% of patients with coronary artery disease already had mild vascular cognitive impairment, the stage before dementia, but a stage that also puts you at risk for developing dementia. Cardiac disease is also associated with increased oxidative stress. My group wondered whether oxidative stress might be contributing to vascular cognitive impairment. We found that if we studied 110 people with coronary artery disease, 29 of them had early cognitive changes. In this study, we found that blood markers of oxidative stress were significantly elevated in patients with mild vascular cognitive impairment compared to patients with coronary artery disease who did not have mild vascular cognitive impairment. And the actual data for this are shown on your right-hand side. Here are our oxidative stress markers, and here's a group with no vascular cognitive impairment who have relatively low levels, and the patients who did have vascular cognitive impairment, who had statistically higher levels. We also know that an active lifestyle is important to help prevent or delay cognitive impairment. In this study by Northey et al., they evaluated 36 studies that showed that physical exercise improved cognitive function in older adults. In this study, that was defined as adults 50 years of age or older, regardless of their baseline cognition. So it works in people who are cognitively normal and above 50, who have mild cognitive impairment and are above 50, and it even helps in patients who already have mild to moderate Alzheimer's disease. The interventions in this study included aerobic exercise, resistance training, multi-component training, which means combining, for example, aerobic exercise with resistance training, and Tai Chi. Those were all significant. And as we heard, the Heart and Stroke Foundation currently recommends at least 150 minutes of moderate to vigorous intensity aerobic physical activity per week. Knowing this, we wanted to see if this would help our population of patients with coronary artery disease. So we measured their cognition before and after a 6-month exercise program. Unfortunately, not everyone had the expected improvement in cognition. We found that the CAD patients who improved had much lower oxidative stress compared to the coronary artery disease patients who didn't improve with the exercise intervention. And this graph shows the actual data. Here's the oxidative stress in those who improved. That's lower compared to the oxidative stress in those who didn't improve. And the two groups were given personalized exercise prescriptions, and we showed by looking at their oxygen uptake that they both groups actually improved their fitness level to the same degree. Nevertheless, the group who had high oxidative stress did not improve cognitively as much. To address this, my group is currently running the MOVE IT trial. MOVE IT stands for the Memory and Antioxidants in Vascular Impairment trial. It's a clinical trial where we're evaluating giving an oral antioxidant supplement called NAC at 2,400 milligrams per day, so a high dose, as an add-on therapy to try and improve cognitive function in patients undergoing cardiac rehab who are at risk for vascular cognitive impairment. This study is currently recruiting. As I mentioned, NAC is being given. NAC stands for N-acetylcysteine. It's a supplement that crosses the blood-brain barrier, and it increases one of the major antioxidants that your brain naturally produces, glutathione or GSH. We're excited about this because as a supplement, it could be made widely available for a reasonable price to many Canadians. It's also important to find predictors of response, as only some people benefit from each of the interventions. Our pilot data that I showed you measured oxidative stress in the blood, but ideally we would like to measure it in the brain, and we can do that at Sunnybrook using magnetic resonance spectroscopy, or MRS. Our plan is to measure the major antioxidant, glutathione, in the brain and compare glutathione in patients who have MVCI, mild vascular cognitive impairment, compared to controls, to see if what we found in the blood is actually being reflected in the brain. It's also important to see if brain GSH predicts response. that if we measure it at baseline, we'll see if we can identify patients who have low brain antioxidant GSH, and those people may be the ones who might benefit the most from treatment with an antioxidant. Third, we also want to look at something called target engagement. We can see if the NAC changes brain GSH, so if the drug we're giving actually changes brain GSH, and whether those changes are related to the cognitive improvement we see. And that's important for validating that the drug that we're giving is actually causing the cognitive change that we're seeing. We're also evaluating transcranial direct current stimulation, or TDCS. That's a neuromodulation technique. Neuromodulation by TDCS has been shown to improve memory in some people with mild Alzheimer's disease, but the cognitive improvement that you see is highly variable and not everyone improves. But we do know that TDCS is activity dependent. That means that you get a better response from TDCS when the brain cells are already active. So we're asking the question, if we can prime the brain cells with exercise, can we actually enhance the cognitive benefits of TDCS, or neurostimulation? And for that, we're running the EXPRESS trial, a combined exercise and transcranial direct current stimulation intervention for cognition. We're also excited about this study because TDCS is available and can be done at home, and we could also give people personalized exercise prescriptions that could also be done at home. So it's very feasible to be given to a wide number of Canadians for prevention. In summary, I've given you some examples of ongoing research to identify new targets to improve cognitive health, as well as to evaluate novel therapies that target those interventions. The research projects that I've highlighted today are aiming for early intervention. Research in dementia now recognizes that actual dementia pathology begins decades before symptoms appear, and early intervention may be the key for prevention. Finally, it's not a matter of one size fits all. Personalized and precise interventions, we hope, will be the key to optimizing effectiveness in everyone. Thank you very much. Sandra, I think you're muted still. I was going to give that as one of my examples.
Okay, well, I was going to say that thank you for giving some suggestions for the answer to the question that Dr. Rabin raised at the end of her talk about what can you do. But this concludes our formal presentation, and we now can begin the question and answer period. You can still submit a question if you wish, but we do have quite a few of them already accumulated over the last, kind of couple of weeks, I guess, since this has been anticipated. And I'll start with, it's hard to cover everybody's questions, but I'm going to start with some that have to do with age of onset. And this maybe is to Sarah, because it's more to do with sort of diagnosis. And it's just wondering about, there's several questions asking the same thing. Is there a minimum age to have dementia? Is there a rise in dementia in patients in their 50s or even 40s? I have a good friend who was diagnosed at 56 and she's now 59 and she's progressing rapidly. So there are some other questions along the same kind of same theme. Somebody with Parkinson's disease and the person is quite young, and then they're having trouble actually accessing some of the services, right? Because they tend to be for people over 65. Mm-hmm. So Sarah, could you, from a physician's point of view, could just comment on some of those issues?
Absolutely. Yeah. Thank you. Thank you for those questions. Early onset dementia is certainly an area that is important to be thinking about and talking about, because dementia, as we discussed today, is a progressive condition, and it can affect people at all stages of life, including at the prime of their life. And so early onset dementia is actually a small proportion of the population of patients with dementia. It's less than 5%. When I hear that statistic, I think, must be more than that because I tend to see a lot of patients with early onset disease in my clinics. But again, these statistics are not perfect, and a lot of times they aren't reported well. But certainly it is the minority of cases, but it's quite profound and tragic at any stage of life, and certainly in someone's earlier years. We define early onset dementia as someone who has onset of cognitive symptoms impairing life before the age of daily function, before the age of 65. So we know that cognitive impairment is more common as you age, and that dementia, which is when cognitive impairment impairs your ability to function on a day-to-day basis, is much more common with normal aging. And with each decade that you age, your risk of dementia increases. But the early onset cases are really those who have below the age of 65. And there is no real minimum age for dementia. I can tell you, there was a case I saw in my fellowship of a patient who had onset in age 29 and died at age 31. So certainly it may not be as common given the fact that age is the most potent risk factor, as we discussed, but it certainly can affect you in the younger years. Now, that's not to say, if you're in your 20s or 30s or 40s and you're having cognitive impairment, that's the most likely, because it certainly is not. It would be quite rare, as I described, of overall the causes of cognitive impairment would be much more likely to be other things. But in the early onset cases, that in those rare cases, it can be seen quite early. And then the next question is about that I heard there was, what does it look like in that population? And then also what resources are there? So it can look quite different depending on the type of dementia. You mentioned Parkinson's disease. So Parkinson's disease, again, tends to be a disease that's more common as you age. It's a motor impairment. So typically you have symptoms like tremor, stiffness in the muscles, slowness in movement and walking. And it can, as you have it for a period of time, can also lead to dementia, and it can happen at a younger stage as well. And the resources can be quite tough because dementia resources are often targeted to the mass. That would be a lot of elderly people. So it can be quite isolating and quite difficult to manage at the younger stages with young families, with caregivers or partners who are in the workforce. And it can be isolating if you try and access resources that are really geared towards an older population of patients. So there are some resources within the community that provide particularly support to loved ones and caregivers of patients who have early onset disease. There's a wonderful group run out of Baycrest, actually, Baycrest Hospital, by Renee Clements, who's a social worker there, particularly for early onset disease. Alzheimer's Society has resources for early onset disease. Parkinson's Society would have some resources as well. Now, when we talk about the Alzheimer's Society, people often think about it has to be Alzheimer's disease, but it doesn't. It can be any type of rare dementia. It's sort of an umbrella term, dementia, but Alzheimer's Society is sort of the term that's used, but really anyone can access resources from there who have cognitive impairment. And one thing to mention is that genetic causes are something we think about in patients who have early onset before the age of 65. It's around 10, 11% or so of cases under the age of 65 are genetic, meaning that there's a genetic mutation, often one that can be passed from generation to generation. We'd refer to that as something called autosomal dominant, which means you have a 50% chance of passing it on to subsequent generations. And there are actually some unique clinical trials and other studies that might be available to patients who have early onset disease and who may have a genetic mutation. So certainly getting a good assessment and getting involved in research trials would be important. I'll leave it there, but there's obviously a lot to say about early onset disease.
Now, I just add to that, Sarah, the person who maybe started to get sick in their 20s and 30s would likely be the autosomal dominant, because that can be expressed as young as in the 20s and 30s. And in fact, there are clinical trials right now that are going on at Sunnybrook that are, first of all, for people who have a different kind, frontal temporal dementia, they're just gathering information about that condition because it can also be inherited. And also the autosomal dominant Alzheimer's disease. Dr. Vaselis is leading something called the Diane-2 trial, which is giving some antibodies to individuals who are at risk, because you can know they're at risk from the gene, and they may be in their 20s and 30s, and you're trying to prevent it from progressing. So that's something that's new and under investigation at Sunnybrook. I'm going to ask, there are a whole bunch of questions about diet, and I guess this can be open to anybody to answer, but maybe Jennifer and even Krista, because you were talking a bit about diet as well. There's something called, I don't know if you've heard of it, there's something called the Dresden diet protocol, developed by a dementia specialist in California, and making some claims about how it can prevent, delay, and sort of treat Alzheimer's disease. Do any of you know much about this particular diet? I think it includes fasting. It includes sort of like fasting for part of the day, and includes some good advice about some of the antioxidant foods and so forth. But there's also there's a commercial aspect to it, and I think there's a whole raft of tests that can be done in your blood, and then you're kind of guided by what those patterns are to do this or that. But it's actually quite expensive, and so it's not something that everybody can afford, but it is certainly something that's been brought to attention. And I think there are some physicians who offer this and guidance on that diet that are in the Greater Toronto area. But other aspects of diet, you were talking about nutrition and physical exercise. And so what about sleep, Dr. Rabin, in some of the work that you've been doing on prevention? And can you comment a little bit about the importance of sleep? It was sort of hinted at also by Krista, and the removal of the garbage overnight. I think was it you, Jennifer, or was it you, Krista? I forget which. Can you just comment on sleep as well as another important, something very important for people to take into account when they're trying to live a healthy life?
Sure, I can start, and then maybe Krista can add. Yeah, so research has shown that sleep is very important for the brain. As I discussed in my presentation, sleep is very important for clearing harmful toxins from the brain. So not only amyloid pathology or Alzheimer's pathology, but also pathologies associated with other types of dementia, including Parkinson's disease and Lewy body disease. So I think we're still learning a lot about how sleep impacts dementia risk. So I would say it's very much an ongoing area of investigation, but really all the research points to how important sleep is for the brain. I will also mention there is probably a bidirectional relationship. So we in people who have a diagnosis of Alzheimer's disease and who are showing cognitive symptoms, they tend to have sleep problems. So we see sleep issues as a result of Alzheimer's disease, but also as a risk factor for Alzheimer's disease. Krista, maybe you would like to add to that?
Yeah, that's such an important point that you're making, that you can also have sleep disturbances as a neuropsychiatric symptom once you have Alzheimer's disease, which in turn, if you're living with someone, can give them sleep disturbances in the caregiver because they're worried about their loved one wandering off at night. So there's also things like obstructive sleep apnea that are associated with sleep abnormalities as well that may contribute, even more. I loved your analogy of the dishwasher running overnight, but there's also problems that can lead to excessive daytime sleepiness, and sometimes there are actual causes of it, like obstructive sleep apnea, which can be treated, as we know, with a CPAP machine, and they're coming up all the time with interventions that are easier to use than a CPAP machine.
Yeah, the thinking is that sort of 6 to 8 hours is what most people should be sleeping. If you need more than that, unless it's a lifetime habit, some people need less and some people need more their whole life. But if you're sleeping more than that and you're later in life, that may not be so normal either. it may be the beginning of change that is related to the onset of dementia. Just like, of course, not sleeping enough, it's both a cause, it's a risk factor, and also it makes it very hard to function if you don't get enough sleep. So I won't ask if you were on call last night, Sarah, or anything like that, because
I'm on call tonight, actually.
oh my God, so somebody's protecting you. All right.
Yeah, Lauren is confirmed for me.
So sleep apnea is really important. And I mentioned that we've got one of the largest group of sleep neurologists in the country, actually, with a great deal of interest in sleep apnea. There are new devices that can be helpful. And I think that may be more tolerable. But I think it's overlooked a lot because everyone thinks everyone snores. It's not a big deal, but it is a big deal, and it's treatable. And when you have apnea, you are unable to breathe, so you have an alarm reaction because you're obstructed, and you also have hypoxia. So these are not good things for the brain. So sleep apnea and sort of getting restorative sleep is really important as another way to protect the brain. So there's a question here, I think, for you, Sarah. It's about family physicians and during a pandemic. How do you get an assessment and diagnosis when family doctors aren't seeing patients in person due to the pandemic? Maybe you should be giving your talk to family doctor associations, but there are a lot of family doctors who have switched to virtual care. But it has to be done. I think one of your most important messages is if you're doing that and you're not sure about something, that an in-person assessment is important to verify something that might be relevant that you weren't able to do. But you just want to answer that question because
Yeah, absolutely.
It's gone virtual for everybody.
For sure. I think one of the things that I highlighted in my talk was that a diagnosis of dementia can be done at many different levels of physician care. It can be done at the level of primary care or specialist care. And certainly during the pandemic, the lack of access to in-person visits was a barrier for a lot of dementia diagnoses. And I've seen a huge influx of referrals, and I'm not sure what that's due to. It could be a number of factors, but I think a lot of patients were not necessarily being seen and triaged. So I think part of this will be, having virtual care competencies and confidence really instilled throughout the health professional field, both to physicians, nurses, allied healthcare professionals, to really get that comfort to be able to do assessments virtually. And then at the same time to really work on studying what we're doing so that we know that we're doing it well, that it's not impacting the quality of care, the accuracy of the diagnosis, things that I mentioned, like the patient-physician relationship. And as Dr. Black just mentioned, most importantly, really being able to know the limits of virtual care and triaging which patients are appropriate for virtual care and which might not be. And at the level of the general practitioner, not being able to see a patient in person is not necessarily a significant barrier if virtual care can be instituted, utilized properly, and used as at least a triage tool to be able to access perhaps increasing level of care in terms of specialty consultation or other resources within the community.
Sort of related to this, and all of you can weigh in on this, was a question that says, individuals with dementia benefit from environmental stimulation. Is there room for virtual reality hardware to assess them in their daily functioning? And what other modern tools of technology can help prevent worse outcomes in patients with dementia? I guess it's really, you were sort of hinting at it too, Krista, a little bit, with the TDCS. Can you kind of comment on some of the new tools? There's another device that uses near infrared spectroscopy, and you put it on your head, and it may stimulate the innate immune response to pathology like Alzheimer's disease. Any thoughts on that?
Yeah, there's so much that we can do with technology. We can use it. There are smart homes now that they are trying to design for patients who are either at risk just because they're elderly or for other reasons. And these smart homes can remind you to do things. They can look for gait changes and slowing down of things that you're doing and warn you that you may be developing some cognitive symptoms. So there's all kinds of things that smart homes can do for diagnosis, and also to support you if you do have memory problems, for some of the reminders for day-to-day activities. So that's definitely an active area. To talk about, any stimulation, even virtual stimulation, of course, included in that would be good for you. So I don't see any reason why not. And I know that a researcher actually in France who does a lot of virtual stimulation for patients who have mild Alzheimer's disease, and uses that in 3D as a method of stimulation. And it helps them with some of their neuropsychiatric symptoms. So that's what I'm aware of that's going on.
And Jenny, can you also comment on along the same lines as kind of virtual assessment that Sarah's talked about, doing virtual cognitive assessments, like actual neuropsychological tests that might be doable over the internet as opposed to in person? Because I know you're interested in and have been developing some of this, especially things that might be even language free, given the multicultural nature of multi-linguistic nature of the Greater Toronto Area. Do you want to comment on that?
Yeah, thank you. That's such a great question and so relevant these days. So some of our neuropsychological tests or our cognitive tests are very easily to translate to a virtual model, but some tests become much more difficult. So when patients have to draw things, for example, it becomes difficult to assess how they're drawing things. Also difficulty when assessing certain aspects of language or memory. So it hasn't always been an easy transition, but I would say that we're working on it. And we also have to think about how the tests were normed in the first place. So all the tests that we give in a neuropsych assessment have been normed on hundreds or thousands of people, and all of those assessments have been done in person. So when we start to move our assessments to a virtual environment, it changes the nature of the tests, and then we can't necessarily rely on the normative data that we've used. So I think we really have to put our clinician hat on and use our judgment more so than we might have to when doing an assessment in person.
Okay, there's some more questions coming in. One of them has to do again with sort of sleep, and that is, do naps provide a protective benefit with respect to sleep? So is it okay to nap during the day? Do you want to comment on that, Sarah, maybe? Because certainly in Parkinson's disease, there's a lot of napping during the day, maybe because of disrupted sleep at night.
Yeah, so that's the biggest concern with napping, is you really want to be maintaining your regular sleep-wake cycles so that you can get really efficient, good cycles of sleep throughout the night. And you're awake and alert throughout the day such that you're able to integrate with your environment, participate in social stimulation. Often napping during the day can be a sign of one of two things that is of concern. One is the one that we've just talked about, which is that sleep at nighttime is not good enough. Perhaps there's sleep apnea and it's causing you to be sleepy during the day, or some other sleep disorder that's impeding your nighttime sleep. And therefore, a nap during the day might actually be a symptom of a sleep disorder at night. The other thing that it could be a sign of is insufficient daytime stimulation, which is actually what I see more commonly in my population of patients, is that patients don't have enough to do during the day to keep them interested in staying awake. And so napping is just sort of a way to pass the time. And the problem with that is, number one, you aren't getting the social stimulation, but number two, it then becomes harder for sleep initiation at nighttime, falling asleep, sleep maintenance, staying asleep. And so what I always recommend to patients is, as much as possible, try and keep your sleeping to the nighttime and keep yourself awake during the daytime. And if you're having difficulty with that, then talk to your healthcare provider about ways to increase daytime stimulation and improve sleep onset at nighttime and maintaining sleep.
I'll comment on that. I think what happens in Parkinson's disease, because of problems with dreaming sleep when you're supposed to not be moving, they're moving and they're disrupting sleep throughout the night. So they actually are sleep deprived. And people with Parkinson's disease often nap through the day, making up that deficit. But I will be a proponent for an afternoon nap because in fact, it may be restorative. And I think you think of the Mediterranean, where it's an institutional, kind of normality, which is you nap in the middle of the afternoon, you have, go later at night, and probably it arose because of the climate, the climate, in that particular area. And that may relate to the fact that there is actually in the 24-hour rhythm, circadian rhythm, there is actually a hypoarousal time that's in the middle of the day around when the sun is at its highest. So it's thought it maybe had to do with evolving from Africa, where you got out of the sun in the middle of the day, or you would, burn to a crisp, or you'd be eaten by a lion or something, if they existed back then. And so I think it doesn't hurt to have a limited nap after lunch. And actually, if you have a protein lunch, the tryptophan of the protein actually makes you sleepy. And I always joke and say, and you'll all relate to this, never be the lecturer right after lunch for any class of students, medical students or whatever, because they all go to sleep. And that go to sleep is because, you're sitting, you're quiet, and you tend to fall off to sleep. So I think sometimes that can be okay. And people can, there are some actually sleep specialists who talk about enhanced performance, cognitive performance after a nap, because sometimes people will consolidate information and then be able to perform better after a nap. So I don't think it should be done throughout the day. That's usually pathological, but I think it was probably that the Quakers and people that came to North America were workaholic, and it was wrong to ever, take a break. And so that's sort of been our habit in North America, but there are whole cultures where it's almost institutionalized, and it probably reflected something that was working for those cultures. I just want to throw that in.
I'm just to comment on that. I think that's a good point. I think as long as it's not a symptom of something else, then a nap, certainly, I can tell Dr. Black's a napper.
Yeah. Well, no, I can nap anytime because I'm always sleep deprived. But anyway, the idea is that this is a natural time to do it. That's probably the best time to do it. It's not so good to nap other times of the day. A few other questions here about some medications. What about metformin for non-diabetic people? Can it be beneficial in dementia? It reduces maybe inflammation. Maybe Krista, you're pretty expert on diabetes and sort of some of the.
Yeah, I'm not an expert on diabetes, but I can talk a little bit about metformin. Even in non-diabetic people, it can have the same effect. We know that diabetes is characterized by insulin resistance, and that metformin can help with that. So it helps your cells, and in this case, your brain cells, get the glucose that it needs into the cells to help them work. So there's the direct effect, and that metformin is thought to have some indirect effects also, that effects that have just been seen in the test tube so far. It helps with things like oxidative stress, and it helps with neurogenesis. So there are studies going on right now. There's a large study called something like LEAD, I think, that's looking at metformin, but in people who aren't diabetic, just to help with aging, because we know that you can have increased insulin resistance with aging. So that big study is going on right now. And there are studies looking at metformin in Alzheimer's disease and Parkinson's disease for the same reasons. As yet, we have no solid evidence, but it is an area that is increasingly being studied, and we hope to have some more solid answers in the next few years to look at the value of metformin. So far, yes for theoretical, no for hard evidence.
So there is another diabetic drug, semaglutide, which is going to be studied actually at Sunnybrook as part of our clinical trials efforts. Looking at semaglutide, which is a diabetic drug, for people with mild cognitive impairment, early Alzheimer's disease. And they also have a branch of it that will be allowing people who have this white matter disease, which is the vascular disease that can contribute to accumulation of amyloid. There's one question about why is it hard to get rid of amyloid and tau from the brain? It's the amyloid that's trafficking out of the brain along the perivascular spaces. And that's where if you have vascular disease, stroke disease, for example, that's where your arteries are very healthy arteries and healthy veins are very important for the normal health of the brain, including the removal of amyloid on a nightly cycle of slow wave sleep. So that's part of the answer there. But there is a trial underway for using another diabetic agent for that very purpose. It's to try to actually treat and prevent decline in people with early stage Alzheimer's disease. There's a question here about statin drugs. Do they increase the risk of dementia? In fact, statin drugs are extremely important for protection after a heart attack and stroke. So they actually help to prevent dementia in people who've had stroke and heart attack. But I think there were some theories going around many years ago that somehow they might increase the risk of dementia. The drugs that do have to be avoided are the drugs that have anticholinergic effects, of which there are many. And so those are drugs that are best avoided, or you try to choose a member of a class of drugs that doesn't have that. So for example, antihistamines often have anticholinergic effects. So if you have allergies or you need antihistamines, you try to get ones that are non-drowsy, meaning they don't have anticholinergic effects. Some of the drugs for stomach protection, for gastric acidity and reflux. Also, just recently, one of our team members, Dr. Swadfager, in his group, showed that some of those drugs are safer than others in the long run for dementia. And I think it was the proton pump inhibitors did better than the drugs like cimetidine that often have anticholinergic effects. So there are drugs that are better or worse for you that you need to be aware of. Oral medication.
Maybe I could just comment on that. I think we're pretty good at avoiding medications we know about that have strong anticholinergic effects, but there's also an anticholinergic burden scale, because what happens is with polypharmacy, you end up on a bunch of drugs that have a tiny bit of an anticholinergic effect. And they can be prescribed by different people, but when you add it all up, you have a high anticholinergic burden. In our coronary artery disease patients, we actually took an anticholinergic burden scale and we added it all up and showed that the impact that had, and they didn't get the benefits that we expected from exercise cognitively. And when we look back and did the anticholinergic burden scale, even though they weren't on any drugs that just one drug had a high anticholinergic, when you added up all their burden, it became important. So we changed clinically and made sure that when people came in, we actually did the anticholinergic burden scale and look at all the medications they're on and add them up.
That's a good point. There's just a ton more questions coming in here. My goodness. How do you assess, what's the process to check what stage an 85-year-old is at cognitively? So I guess it's screening tests. Do you want to just comment on that? Any of you can do so? There's screening tests that we use to see if a person is performing within normal limits for age. Jenny, do you want to talk about that?
Yeah, sure. So, as Dr. Mitchell mentioned earlier, as we get older, we know that our cognition gets worse. So our memory gets worse as we get older, and other abilities also get worse. And that's completely normal, but sometimes people will experience changes that are perhaps greater than normal. And that's where a screening measure comes in. So these are short measures, short assessments, usually about 5 to 10 minutes, where patients are asked to do a variety of things. So they're asked orientation questions. So what's today's date, or where are they? They're asked to learn and remember a short list of words, to do a drawing like a cube and sometimes a clock. And then the scores are added up, and there are certain cutoffs. And so if someone were to score below the cutoff, that would suggest that person might be at risk for mild cognitive impairment. And in that case, it would be best for the patient to be referred to a specialist or to a neuropsychologist for a more detailed assessment.
I think the most commonly used one worldwide, because it's been translated into about 60 languages, is called the Montreal Cognitive Assessment. And it's got some word recall and some drawings and attention tasks. And it's remarkably effective. It sort of replaced something called the mini mental state, which is not quite as sensitive. And it's widely used in all kinds of clinics. Family doctors use it as well. Parkinson clinics, even congestive heart failure clinics are starting to think of using stroke clinics. I think it's probably the most widely used in many countries, including there are Chinese versions of it. There's Arabic versions. I mean, they're widely used. And of course, it gained some fame because Trump took his test, I think, a year or two into his presidency, and they published it in one of the California papers. Of course, it revealed the test, and he did fine on it. So he decided that he was quite okay. Anyway, those are what are most widely used as ways of more formally looking at it. But often it's clues in how the person's doing on a day-to-day basis. And one of the questions, actually, is sort of an interesting question. And they said it was something like, how do you approach? What are the best ways to approach a parent who's showing signs of dementia without causing anger? I thought sort of an interesting question. Anger or alarm or whatever. And what this is revealing is a tremendous stigma, the tremendous shame that people feel, right, with respect to being labeled with what we call the D word. If you want to comment on that, I'd be interested in all three of you. It's a very interesting question that it would even be asked.
I'm happy to start. So I think it's a really important question because there are many cultural differences, and as you mentioned, stigma that surrounds the idea of what is normal aging and what does that look like. I think the most common misconception is that Alzheimer's disease or dementia is synonymous or is the same thing as getting old. And, I think there's senility is a word people often use to describe both old age and difficulties with memory and thinking. And people, are used to seeing confusion that arises later in life. And many people think that it's just normal aging. And of course, we can see that that's not true, right? Dr. Rabin gave a great example of how a brain can be filled with abnormalities and yet still function perfectly well. And the opposite is true. And so how do we actually approach someone when there's the concern that it might be met with, oh no, this is just normal aging, this is nothing. And there is no right answer to that. And it's not going to be easy. But it is an important conversation to have. When you're concerned about a loved one's health, whether it be their heart, whether it be their lungs, whether it be whatever organ it might be, some of them may have less stigma than talking about their brain. And that's true for mental health issues and it's true for cognitive issues, but it doesn't make the brain health issues any less important or any, something that should be avoided. So the only real advice that I would give is just to say that the conversation, the fear of the conversation may be worse than the conversation itself, but that if you really are concerned about it, you may want to have it in a supported environment. That could look like, if you have a good relationship with your family doctor, asking to join on a family doctor visit where you can be in an environment where someone can help moderate. A lot of the times when patients come to see a clinician, the clinician is skilled in being able to facilitate that conversation, despite all of the concerns you might have from an interpersonal perspective with your loved one. There is a skill that comes about doing it in a supported setting with a healthcare provider. And that might be a good way to avoid some of that conflict. And the other thing I would say is if you are met with anger, you are met with defensiveness or whatever it is, sometimes that's a sign of the cognitive impairment itself. And it can be a manifestation of the cognitive impairment. It can start out as a defense mechanism, but it can also turn into things like agitation and irritability. And that's a very difficult situation to find yourself in. And again, this is not something you need to face alone. And this is the reason why there's healthcare providers and systems in place to be able to support patients and their family members who are facing these problems.
I think it's a great answer. I don't know, Krista, Jennifer, do you have anything else?
I think Dr. Mitchell answered it perfectly. But also, the important point about lack of insight. So it's not necessarily your loved one's fault, and they may not be doing it on purpose, because part of the disease, especially we have the worried well who have subjective cognitive impairment, and they have great insight and they're noticing everything, but by the time sometimes you're actually getting to the disease state, you have lack of insight. So it may also not be their fault that they don't recognize it. And I think that it was a perfect answer to, see your family physician or your specialist, and they can really help with that conversation.
Yeah, I completely agree. Excellent answer. And I think just along those lines, to try to understand where that resistance is coming from can be helpful. And just to highlight one additional point is, sometimes I see patients like these, Dr. Langto referred to them as the worried well, and they'll come into your office and they'll tell you all the things they forgot. They forgot to turn off the stove, the lights, forgot to pick up their dry cleaning. Sometimes those aren't the patients I worry about. It's the patients who come in with a loved one, and when you ask the patient, how are they doing? They say, I'm fine. And then you ask their loved one, and they can go on and on about all of the problems that they're having in their daily life. So I think lack of insight is something to think about.
In fact, when we started doing the first studies of what we called mild cognitive impairment, which is the stage in the evolution of Alzheimer's disease where you have a memory problem. Usually it's a memory problem. There's some other issues you can have as well, but you're still functioning pretty well. So the idea is that you're still competent in your daily life, but you do have an objective impairment. And in recruiting for that and in following people through that trial, what was very interesting is we began to see this process where people may start off being concerned, especially high functioning people. And then as they get worse, they lose insight and they start to not think there's any, there's no problem. They forget. And that brings another whole issue with how do you handle that. And people can get irritated because they genuinely don't think they just asked that question for the fifth time, right? And that's a more worrisome stage. But the other sort of framework that I think we should bring to bear here now is I think we're getting into what may be a new era in the potential for treating neurodegenerative conditions. Alzheimer's may be the most common pathology. By the way, it often coexists with other pathologies. It's not by itself. In fact, at postmortem and series like the one that we were talking about in the NUN study, the religious order study, and so on, only 10% of people with Alzheimer's disease in probable Alzheimer's disease in life actually had only Alzheimer's disease. Now, these are people in their 80s and 90s where they had their postmortem. And they had other things. They had Parkinson pathology. They had some other pathology that's called TDP-43, which we've only known about 5 or 6 years. And it causes severe loss of memory because it affects the memory area in particular. There's vascular disease. You have hardening of the arteries, hardenings of veins, hardenings of the arterioles. So these all are a mix in what happens to people when they get to be in their 80s. So that's something we have to bear in mind. And that's why all the vascular prevention and vascular risk factors are so potent, because they're contributing to that element of the brain, of brain function. There's a couple of other questions here that are taking us into some new territory. They're coming in. One is, first of all, the effects of alcohol. You want to comment on that?
Yeah, I can comment. So alcohol is another risk factor for dementia. I would say heavy alcohol use. I know there's some literature suggesting that, a glass of wine or red wine can be helpful in terms of the antioxidants. So maybe Dr. Langto can talk a little bit more about that. But I think in general, it is really thought that alcohol use is a risk factor for dementia. So best to avoid large amounts of alcohol.
I agree with you completely, Dr. Rabin. The key is in the dose, right? The Mediterranean diet, actually, in some pictures of it, shows that one little glass or half glass of red wine. So 1 glass, but that's it. And there are guidelines for sensible drinking that say that you shouldn't have, and it differs for males and females, and says that you shouldn't have maybe more than 4 drinks a day, any one sitting, and you shouldn't drink every day of the week, and you shouldn't drink every month of the year. So it talks about, the importance of abstinence, and if you do drink, to drink in moderation. Just that 1 little glass of red wine.
Yes, and even those guidelines are changing for another reason, but there was a very important study that was done in France in the emergency department. 4 million people were assessed under the age of 65, and they were looking at alcohol use disorder where you're exceeding what's allowed. And they found that that was the commonest cause of dementia in people under 65. And there's starting to be some reconsideration even of what's allowed, because there's more recent data through the World Health Organization that alcohol use can be associated with various kinds of cancer. And that maybe even what's now considered okay for a woman, what's okay for a man, may be too high for what's actually safe. So I think alcohol, the story of alcohol is going to be, it's evolving rapidly as we gather data from around the world. And some of the guidelines are changing, just like the guidelines for blood pressure have changed because of some studies suggesting that we were allowing people to have too high a blood pressure for the health of their brain, and that we had to bring down what is a normal blood pressure. So it's around 120, not 140, that you should be running at before, at which point you should maybe be thinking about medications or some way to get the blood pressure down. So these are all kind of in flux as we learn more, then we have more things to say. But
I just wanted to add one thing about alcohol is just also that once, not only the idea that you brought up, Dr. Black, which is really important in terms of sustained and chronic alcohol use and the impacts on the brain. It can cause shrinkage of the brain. It can cause short-term memory issues. It can even cause acute confusional episodes that can be very concerning and need immediate treatment. But in addition, that if you already have a diagnosis of cognitive impairment or dementia, that the impacts of alcohol in the brain can be significant. It is a toxin to the brain. It can act as a depressant. It can increase your risk of falls and worsen your level of confusion. So really, once especially, thinking about it as a modifiable risk factor, something that you can do to change the course. And then if you do have a loved one or you are yourself facing cognitive impairment or dementia, really to cut down alcohol to almost nothing.
alcohol, by the way, if people use too much and they don't eat properly, can also lead to a deficiency in a vitamin called thiamine, which can actually cause what seems like a sudden onset of memory loss, from which you never recover. And that's because it's injured some key pathways to memory in the brain. And it's often associated with a tendency to make up kind of nonsense. It's called confabulation, because you don't really have a rein on what might be reasonable in your memory. So it's called Korsakoff syndrome. And it's classic. It's a classic example of an acquired cause of short-term memory problems. And by that we mean short-term memory means memory problem means it's in space and time, remembering something that's happened to you in space and time. It doesn't mean your memory for words or memory for, what the world, what politics is going on in the world and stuff like that. It means it's about personal memory that belongs to you in space and time. That's what we mean by short-term memory problems. So there's another, I think, quite interesting comment here. How about mindfulness to help installing dementia? We should all be doing mindfulness, shouldn't we? But does anyone want to comment on that? Especially during the pandemic?
Sure, I can say a little bit about that. It's not an area I know too much about, but another thing that's bad for the brain is stress. And so mindfulness can be used as a stress reduction technique. There has been some recent studies on mindfulness, so showing that it actually affects some Alzheimer's pathology. So there was a recent study that showed that people who engaged in more mindfulness strategies had less Alzheimer's pathology in the brain. But I think it's a new area of research that we're still learning about. And that's what I know about mindfulness and dementia. So I'll pass it on to some of the others.
Yeah, I would just add, I think that's exactly right, that the link there is really with the effect or impact of stress on the brain, especially non-combated stress. So significant stressors on the brain can be really bad for a few things, including the development of cognitive impairment. When we talk about subjective cognitive complaints, which is people who are really heightenedly noticing cognitive difficulties, one of the most common causes of that is underlying primary psychiatric disease, which can be things like anxiety and depression. And what can happen there is that parts of the brain that are really important for telling the brain that it's not doing well, like fear signals, et cetera, can be an alarm. And the rest of the brain is kind of hijacked and not functioning at full capacity. So you can't pay attention to where you put something because you're in fear mode all the time. And what mindfulness introduces in that scenario is kind of strengthening the front part of the brain to be able to then give signals to the rest to say, we're okay, calm down, focus on what you're doing, focus on where you're putting your keys and what you're doing in that moment. And that can be a really important intervention in those cases to help improve memory and thinking in someone who the driver of their cognitive issues is something like anxiety or low mood.
So I'm going to, we're going to be running out of time soon. It looks like we're going to go right up to the time allotment. And there are a couple of themes here, just very quickly. These are quick answers that are somewhat along what you were just talking about, Sarah. One is, there are two questions here. Does having a psychiatric condition like schizophrenia impact the risk of developing dementia? And then someone else asked a question about, for people who, well, partly it has to do with people with born with limited intelligence ability, let's say, for example, Down syndrome, and the risk of, what does that mean in terms of the risk of getting dementia? So those are sort of specific answers to that. And then there's the other just concept of cognitive reserve, and the idea is that people who are highly intelligent, even when you're doing the cognitive tests, you have to take into account education and ability, because somebody who's just average, that may represent a decline for somebody who normally would be doing better on certain kinds of tasks. So can we talk about the conditions like schizophrenia? And maybe Sarah, you can comment on that.
Sure. So we know that chronic severe psychiatric illness, things like schizophrenia, things like bipolar disorder, especially those that are poorly controlled and have been long-standing, can have impacts on brain function. It can lead to global shrinkage of the brain. It can also lead to what can look like a dementia type process, and they may independently be at higher risk of developing things like Alzheimer's disease and secondary pathology as well. In particular, ones like Down syndrome, genetically, they're going to be highly predisposed to develop particularly Alzheimer's disease, usually at an earlier age. And that's mediated by their genetic mutation. And that's something that has borne out pretty clearly within the literature. Schizophrenia and other chronic psychiatric illnesses are something that are still being studied and looking, so there still needs much more to be revealed, but we do see an increased risk of cognitive impairment, changes in the brain, and neurodegenerative disease development.
It's interesting that in some people think that women who get schizophrenia later on in life and then are treated with the appropriate and more sort of tolerable neuroleptics actually may normalize and may in fact age better than their male counterparts and actually evolve in a different way than was expected in the past, because the medications that are available to treat them now are less injurious to the brain. So there's some interesting kind of developments there, and we might be moving in a direction where there are better ways to treat people with these chronic conditions that will be more friendly to the brain than they have been in the past. So another question has to do with COVID. I guess we're going to end on some reflections on this era that we have been in. And that there are two questions here. What does having COVID-19 physiologically do to somebody already diagnosed with dementia? Does it exacerbate the dementia? That's one question. The other one is, any thoughts on long COVID long haulers and brain fog in relation to what the future holds for these individuals. So just some thoughts on that. A lot of this is just speculation, but some thoughts on that from any of you. Maybe Sarah first.
Sure. So the first question was about the impact of COVID physiologically in a patient with dementia. And I think it's a question that, as you mentioned, is something that we're still going to be learning about and understanding. We do know that COVID can cross what we call the blood-brain barrier, which COVID-19, the virus, the SARS-CoV-2, can enter into the brain and cause a number of neurological complications, things like stroke, things like confusion, or what we call delirium, which is an acute confusional state. And certainly the impact of those events on someone who has dementia can have an impact on their course of disease. So we know that delirium, which is again that acute confusional state that someone might be at higher risk of once they contract COVID, can then increase the risk of having more rapid progression of their underlying dementia and a lower baseline level after they've had the virus. So those are some real implications and concerns from developing COVID-19. And then the second question is equally as controversial, which is this concept of long COVID. And this is certainly something that we need to do a lot of work to understand before we can make any real meaningful conclusions. But what people have been seen to have is that once the initial infection clears and the virus clears, that there can be lingering neurological symptoms. And that includes things like fatigue, problems with attention and memory and concentration, as well as some other symptoms. And there's some great research and studies, even here at Sunnybrook, looking at the impact of COVID-19 on the brain, particularly in these patients who are having longer standing symptoms. And we know that there's probably a very important role for viruses in our development of brain pathology, but we still have a lot of work to do to uncover and really fully elucidate or show what that relationship is. But it's likely an important one. And COVID, because it's so widespread, is a really neat and nice opportunity, despite all the negative, to study that in an important way and try and understand its impact on brain physiology and symptoms of cognitive impairment.
Yeah, I mean, I think Sunnybrook is actually doing, we call it the neuro-COVID study. It's something we started right away, doing some fancy brain imaging, and with Baycrest also some very fancy memory tests and other kinds of cognitive tests, as well as EEG. And it was already apparent, this was in the first round, it was mostly individuals we were comparing people who had symptoms, but they were COVID negative on testing, and then those who were COVID positive, but were isolating at home. There were some people who were admitted to hospital, but most of those individuals seemed to be reluctant to come back after they got home to do any kind of testing. They just wanted to try to get better. So we don't have too many of those. But what was interesting is we saw in the first round, when it was the original COVID-19, which now is mutated in various ways, that it seemed to be getting into the brain in some people. And it's thought that it goes through the nasal epithelium, the lining of the nose. And we could see it in the part of the brain that has to do with smell. They're called the olfactory bulbs. We could see it in the inferior part of the frontal lobes, where it seemed like we were seeing signal there that shouldn't be. And the only thing that differed in these people was that they had COVID. And they are showing it in a part of the brain that has to do with kind of smell in animals. It's called the orbital frontal gyrus. And we saw in some people more white matter changes than we would expect for their age, because many of them were in their 40s and 50s. So I think we don't know what that's going to mean, except that vaccination probably makes it much less likely that the virus is going to get into some of those other areas, I think now, because it can protect you from the spike getting in through the epithelial cells and the endothelial cells. So I do think we're just going to have to see what happens. And after the SARS-CoV-1, I know in my clinic, we were seeing many of the healthcare workers in the north and east part of Toronto, and also Sunnybrook was hit pretty hard by that outbreak. We saw people who could not get back to work. And it was like a year or two afterwards, and they were just different. They had brain fog, they had chronic fatigue. They were mostly healthcare workers. So I don't know what eventually happened to some of those individuals. We tried, they got some cog rehab and so on, but I think some of them really never got back to work. I think we're going to see a little bit of that, if not a lot of that, as everyone takes a look worldwide at the impact beyond just the immediate case of illness that people have. So I think it's also possible, I think somebody made a comment about this, that Alzheimer's disease itself, we're not quite sure if it might not represent in some cases viruses that actually do inhabit the body. We have we have viruses that take up residence in our bodies and in our brains. Herpes simplex is one. So some people get the cold sores that come out from time to time. And the other is shingles, herpes zoster, which is the chickenpox virus. So they live in us. They live in a lot of animals, actually, these viruses. Viruses are showering down and they're penetrating all kinds of living things. And they apparently are part of the evolution of life forms on the planet. And so Alzheimer's disease itself, the amyloid and the tau, may actually represent a reaction to something that's hurt the brain or invaded the brain, like bacteria, viruses, or if you have a stroke or head injury. You get a little burst of amyloid in response to a stroke or head injury. And that amyloid and the tau are sort of a tag team for shoring up damage. So some people have speculated that this might be a chronic, what's called a chronic immune response syndrome, because herpes simplex was isolated in Alzheimer's brains at people with Alzheimer's disease whose brains were examined at postmortem, but it's never been easy to replicate. But it's still in the literature, right?
There's an interesting study actually that looked at ApoE epsilon for homozygotes. So ApoE, which is a risk factor for developing Alzheimer's disease. They showed that people who weren't demented, but who were ApoE homozygotes, had more severe COVID because they had more cytokines released, so more of an inflammatory response because of their ApoE. So it also ties it in with the theory that Dr. Black just mentioned, that people who have this risk factor for Alzheimer's disease could have a greater response due to inflammation that causes inflammation in the brain, which we call neuroinflammation. So they're going to have a greater inflammatory response in the brain.
It's interesting. There was one question, and I'm glad you brought that up, because it was about the ApoE4 gene and genetic tests, pointing out that a lot of young people now are getting their testing done, and they will know that they're at risk for Alzheimer's disease. That usually means they've got one of the ApoE or two ApoE genes. And the question is does this give them an advantage to know they may be at risk, and is there anything they could do? Well, I think you can do all the things that you've been suggesting in terms of prevention, can start at a young age if they have found out when they're in their 20s and 30s, and that's happening more now. So they can do those sorts of things. But the question is it being targeted itself as something that you can change and manipulate? And the answer is, I think there are some studies wanting to target the effects of ApoE itself, because it seems to make the brain leakier than not having ApoE, and that may be one of the reasons that you're more predisposed to Alzheimer's disease, but this is not well understood. But as a finishing note, since we're running now close to out of time, there have been a couple of questions about how does one access the intervention trials and programs from the community that we're doing, and another one, what are the criteria for inclusion in the early intervention trials? First of all, I think I would just answer that if I can take a moment, because we're doing lots of observational studies, and Jennifer, you might want to mention the study that you're enrolling, right now, and just give us a couple words on that. And then Krista, maybe you could talk about some of the studies you're doing. And then I can speak. We've only got 5 minutes. I can speak to some of the intervention trials where we're doing infusions of antibodies and things like that. So Jenny, do you want to just quickly talk about some of the work that you're doing?
Yeah, no, that would be great. Thank you. So we're about to launch a study that's looking at risk and protective factors for cognitive impairment and dementia in a multi-ethnic sample. So the sample that we're targeting is to most closely represent Canada's visible minority groups. So in addition to Caucasians, we're also including South Asians and also people from East Asia, because we know that those are the 2 most populous ethnic groups in Canada. And what we know about the literature in Alzheimer's disease and dementia in Canada is that most research participants are white. And there's reasons to believe that some ethnic groups might be at greater risk for dementia because, for example, we know that South Asians are at greater risk for cardiovascular disease and cerebrovascular disease. So we tend to see higher rates of diabetes, stroke, more severe strokes, strokes at younger ages in people from South Asia. And it would be, we think that there might be higher rates of dementia because these are all risk factors for dementia, but it hasn't been studied yet. And so we're really interested in answering that question. So we're looking for participants between the ages of 60 and 80 who are relatively healthy, who wouldn't mind undergoing an MRI, and also having some blood taken, as well as undergoing some cognitive testing. So memory testing and language testing, concentration, et cetera. And then we're hoping to follow people for 5 years. And that's how we get the most important data, is that when we follow people over time, and we can look at the data that we collected early on to see what later predicts the people who decline, and also what predicts people who don't decline, and what are those factors. So if you're interested, please do get in touch.
So is there a website? Is that through NORMOD, or how would people get in touch with you? And I'm going to say the same thing to Krista.
Yeah, you can email the Rabin Lab, RABIN, lab@sunnybrook.ca. That would be the best way.
Krista?
Great. That's really interesting. And besides these studies that I talked about today that were for early intervention or for mild cognitive impairment, we also have studies later in the disease. One thing we look at is apathy, and we have some studies treating apathy. Dr. Mitchell talked about, the person who sleeps all day and they're just maybe sitting in the room in the dark, and how sometimes they're understimulated. And that's true, but there's some people who are sitting in the dark all day, even when you stimulate them, and no matter what you do, you can't get them to engage. And that can be a sign of apathy. Frequently it's confused with depression, but it's actually a separate syndrome, and it's associated in cognitively normal people with progression to mild Alzheimer's disease or mild cognitive impairment. So it's important to treat. We are running some apathy trials, and even further into the disease, we're running 2 trials that try and help with agitation associated with Alzheimer's disease and associated. So memory research at sunnybrook.ca, or the Toronto Dementia Research Alliance, TDRA, has a website, and you can answer questions and go through and find out which studies you might be suitable for. So you can go to the Toronto Dementia Research Alliance. If you Google it website, it outlines the studies for you. You can answer questions and say, what your age is, and maybe what your diagnosis is, and maybe whether you have agitation or not. And it can help you get a short list of studies. And even better, you can contact someone and they can put you directly in touch with the people who are recruiting for those studies.
Okay, and I can mention that we have intervention trials for pharma trials for antibodies and other interventions against mostly Alzheimer's disease, but there's also some trials that are against a protein that happens in frontal temporal dementia. And also the autosomal dominant Alzheimer's disease patients can also be enrolled in some studies that we're doing. This is with Dr. Macelis. And our group is looking for individuals mild cognitive impairment in early AD, usually milder stage. But we do have some studies that involve people who are a little more mild to moderate, including doing a comparison between two antihypertensive drugs, one of which might have an additional beneficial effect in the brain. And then we're doing antibodies against Alzheimer's disease for people where they have to come in for monthly infusions. I mentioned the study with an anti-diabetic drug. And we're now starting to do studies in people who are cognitively normal, but they have amyloid in their brain that's seen on the PET scan that's part of the workup. And there we're trying to prevent the development and the further progression of the amyloidosis when people are still at a very early stage. Because it's very important to know that the Alzheimer's disease pathology is mounting silently in the brain for maybe 15 to 20 years before you know you have it. People who are APOE4, likewise, will start to accumulate it sooner. And so that's another risk factor that we're looking for. And we're engaged to, Krista and I are doing a study where we're actually looking at people who may not be at risk, who are going to be doing some special memory tests in a scanner so we can tell why people, what is a normal activation when you're doing a memory test, which we can actually see on the scanner as it increases blood flow, to get the idea of what's normal. Because people who are at risk of Alzheimer's disease before they have amyloid starting to accumulate, they hyperactivate when they're doing that test in the early stages. And then as they get worse, it sort of burns out and they don't have any reaction. And that's because they're actually having micro seizures in the circuits involved in those memory formations. So we have quite a variety of studies that are going on. It's in M6 at Sunnybrook. And I guess I can't give you an email right now, but Monica, if people want to contact you, then we can sort of tell them, what the easiest way is to access it. Usually it means that people have to have had some sort of workup. But the folks who are cognitively normal may know they're cognitively normal and they may have no risks at all, or they may know that they're at risk because of their family history. And we have something for just about everybody. So it's very active right now. And there are blood tests coming for Alzheimer's disease. So stay tuned. I think we are over our time, and there were tremendous questions, very thought-provoking questions from the audience, wherever they may be or wherever they are. And we really appreciate people taking the time to ask those questions. Thank you very much to a wonderful panel for tremendous presentations and answering on the spot a lot of difficult questions. And we hope that this has been helpful and useful to people, because we're in a very important era of what we hope will become precision medicine, where we will be able to identify people who have these various pathologies and distinguish those who don't, because a lot of people in old studies did not actually have Alzheimer's disease, but they looked like it, and it turned out they didn't have the pathology in their brain. So this is something now that we're being much more precise about, because we have access to the ways of scanning the brain and producing measurement in the blood. And so it's going to be very exciting, but none of them have worked yet. So, well, it's under debate. One of the antibodies got approved in the United States, not in Europe, and we'll see what happens in Canada. But it's maybe the beginning of ones that are going to be successful. So, Monica, do you take over from here, or oh, wait a second, there's probably something I'm supposed to thank you all. I guess I have. I actually thank you to the audience. We've come, we're a little over time. We've come to the conclusion of our Q&A. And I just want to make a couple more comments. Please fill out the electronic evaluation form, because that will help us plan for future talks and topics for you. And then again, thank you to the speakers for really an incredibly informative evening. Dr. Smith for showing up, and even I think he was sitting in for a while as well, he's a busy guy and very, very committed, I think, to some of the strategic directions of, some of which are dementia care and stroke care in Sunnybrook, coming together hopefully in a new building. And then just keep your eye out for upcoming topics. because this speaker series is on the web at Sunnybrook. And I guess all topics across all of our different programs will come up from time to time. Just open to the public to be informed and ask questions, just like we did tonight. So have a great rest of the evening and remember to get your sleep. Okay, thank you so much.